it simple, I think is important. Let me give you a scenario, Adrian, and you just talk to me a little bit about what your thoughts would be in this scenario. A patient comes to us, they've explained that they've had a back pain on and off for years. Initially, they went to a chiropractor and an adjustment or two or a few sessions with PT, and it resolved it. Then a more serious episode, recurs, and they went to a specialist, which led to an injection and some failed chiro or therapy, and then pain management. They lost hope, so they just coped and reduced their activity. Those things that hurt, they just stopped doing. And you do a physical exam and find there's much more evidence to suggest hyperactive nervous system rather than a lot more of a specific biomechanical problem that needs directional preference exercise or some kind of strengthening or whatever. Where do you start with this patient, and what are your keys, do you feel like?
Well, the classic answer is we start with a thorough evaluation to get to know the person, right? So first of all, we do due diligence, as you said, test to make sure I'm not missing. We do get to tell me the story. What brings you here? What's concerning you? What's troubling you? We do ask deeper questions. The classic therapeutic questions of what makes your pain better and worse, and those we do those. But I'm always intrigued. Why do you think you hurt? What do you think is going on with your back? Now, we can take it to the nth degree where we use motivational interviewing really on the other end of the scale. But sometimes I just place these simple little questions in for a patient like, hey, Jason, what do you think is going on with your back? It tells me what they're thinking. What's their operating metaphor? And it can vary anywhere from, I have no idea, that's why I'm here, to well, I'm glad you asked, because you know what? I have that bulging disc that the surgeon told me about, and it said it's the biggest one he's ever seen. So now I know they're fixated on the disc, and no matter what I do, unless I address that, so sometimes we have to de-educate. So let's talk today about MRIs and bulging discs. And the cool thing is the world is beginning to change, where we know bulging discs are not that big of a deal. Many people have them. You and I know this stuff. So we find a way to explain that to a patient, maybe with the physician's help. Sometimes. So it's I want to know what they're thinking and where am I catching them on their journey. And typically in people with persistent pain, they've got some very strong beliefs, because and it makes sense, right? They've seen the chiro, the PT, everybody has said something. They went on to Dr. Google and Professor Wikipedia, so they got their mindset. And sometimes we have to deconstruct that process. My core is weak. I have a bulging disc. I got arthritis, and my grandpa had arthritis, and he was in a wheelchair, and so they're catastrophizing. So we take this story and start deconstructing it. Is there a problem with knowledge? Are they catastrophizing? Are they fearful? Is there depression stages? And so we start deconstructing it, and then so we know for fear avoidance, we can start deconstructing activities. What are they doing? What do they want to do? So that's how we would do it. And then I would often turn to the patient and say, has anybody explained to you why you still hurt? And it still shocks me that 99% will say no. There's that 1%, yeah, it's my bulging disc. Well, okay, they're stuck on that bulging disc. And we'll have that conversation, but I will ask them, has anybody explained to you why I hurt? And the answer is no. And say, would you mind, before, Jason, I take you out to the gym and go through the stretches the last therapist showed you and review those? Would you mind if I teach you a bit about, why pain can last? And most people are actually quite thankful, like, yeah, please. And then there's those that, nah, just fix me. And those are ones you're not going to necessarily today. Cognitively, they're not ready for it. So we do some nice gentle therapeutic stuff, some nice movement stuff. We treat them with respect and dignity. And often that second, third visit, they come and say, yeah, I've been kind of rude to you. I'm sorry, but I've had a lot on my plate, but tell me a little bit more about that pain thing. So we catch people where they're in their journey, but that's typically the process we would do. Create a therapeutic alliance, trust, empathy, compassion, and then just slowly plant little seeds of peony. Peony is planting seeds. You water it with compassion and empathy and see what happens. Some people grow in front of you and you're like, man, I'm the best therapist in the world. I should get some honor degree or whatever. Another patient blossoms at visit 6. What's the worst one is a patient that you plant the seeds, they don't blossom. You're like, oh crap, I'm the worst therapist. Then they go to your competitor across the street and they plant that last little seed, and ta-da! And I've made a lot of peace with the idea that we're not fixers. We plant little seeds. Where they blossom is not up to me. And so I've made a lot of peace with that. It's cool when it happens in your clinic, because then we're cool. But it's a journey. We just a part of that journey they're going through. Yeah.
Mm-hmm. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.